Hello, I'm Holly Morgan, and on behalf of the investigators, it's a pleasure to present the revived SCAR analysis. Coronary artery disease is the leading cause of heart failure worldwide, a condition termed ischemic heart failure. Despite recent advances in medical and device therapy, the condition continues to be associated with a high amount of morbidity and mortality. Currently, we assess a patient's risk by measuring their left ventricular ejection fraction, with lower values indicating poorer function and a higher risk of the fatal arrhythmia. However, we wanted to see if we could go beyond this crude measure and find out if looking at scar characteristics could help us to better assess risk. Patients were enrolled into Revive BSIS-2, a randomised trial that recruited patients with severe ischemic heart failure from across the UK. 70% of patients underwent a cardiac MRI at baseline as part of this trial, which we collected and analysed. As well as looking at the left ventricular size and function, we assessed the total volume of scar and the pattern of that scar to see how uniform it was. 478 patients were included in this analysis. The average age of patients was 70 years, and they all had severely impaired left ventricular function and extensive scar. We found that the volume of scar was strongly associated with the occurrence of death or an arrhythmia. For every 10% increase in scar, the risk of having an event also increased by around 10%. Next, we assessed how uniform the scar was and how this related to events. As you can see, the higher the entropy or the disorganization of the scar, the higher the risk of events. And this was particularly seen in patients who had a lower amount of scar. Left ventricular ejection fraction was not associated with outcomes in this cohort. We previously analysed the burden of ischemia and its relationship with clinical events for the 181 patients who had stress perfusion as part of their cardiac MRI. In that analysis, we found there was no association between the amount of ischemia present and clinical outcomes, and we hypothesise this was because of the high level of scar in this cohort, which is the key driver of events. The key message from our analyses is that scar is an important predictor of death and arrhythmia in patients with ischemic heart failure. Among patients with a low ejection fraction, those who have more scar have worse outcomes. Conversely, even in those with a slightly better ejection fraction, we might be able to better identify those at risk by looking at the volume and pattern of their scar. Our data suggests that scar assessment should become routine in patients who may be considered borderline based on their left ventricular ejection fraction alone, as some of these patients may require additional therapies, such as an ICD. Read the full paper, out now in JACC Cardiovascular Imaging at the link shown. Thank you very much.